Thank you very much. It's my pleasure to be here, and I'd like to move you from colon to liver, a little bit further from the lower part. But it's still linked to your colon because I will focus on liver metastases, particularly with the primary colorectal cancer. And I am a radiologist, so I will tell you in my experience what is the best tool to detect the liver metastases. And this is the outline of my talk. I will talk about choice of imaging modalities, go on to the gadocytic MRI, which is the hepatocyte-specific contrast agent, the new agent for the liver, and then some imaging pearls, and then conclusions. Hopefully it will be done within 15 minutes. Okay, let's start with choice of imagings. This is the meta-analysis a while ago showing that when you look at liver metastases, it seems like FDG PET seems to be the most sensitive imaging modalities. And then CT and MRI, this is conventional MRI, is pretty equal at about 75%, and then transabdominal ultrasound is the least sensitive. As you can see here, that PET seems to be valued the most for a long time. The question is, do we need to perform PET in every case before liver resection? And at this moment in time, the recommendation is that no, it's not routinely used because of uncertain clinical value, restricted availability. It is expensive, and it has some radiation exposure. And this statement is supported by this good clinical trial, randomized trial in 2014, which compared the use of PET-CT and CT, and they found out that PET-CT do not really change in the surgical management. So based on that, the current guideline, NCCN 2017, still recommend CT as the imaging of choice if you want to work up for metastases, still chest, abdominal, and pelvic CT. And if you have a problem with a contrast, like you have patients have renal problem, they recommend to shift to MRI with conventional contrast. And PET-CT should be used in selected cases, so it's not a routine use. Now I'd like to shift to the role of gadocytic MRI, which is the hepatocyte-specific contrast agent. It is different from extracellular contrast, a conventional MRI. I cannot go into detail how it works, but let me show you by the images. This is what radiologists are good at, just show you some images. Before we go to that, there are a lot of studies circulating around, and you as colorectal surgeon, you're probably aware of this, that more and more studies shows superiority of gadocytic MRI over conventional MRI and CT. And people talk about this contrast agent, that it is a little bit expensive. Yes, it is expensive, more expensive than other MRI contrast, but it is require less additional imaging. It's more like one study and you get the answers. So in fact, if you put cost of re-imaging, cost of modifying or unnecessary surgical management factor into the equation, Dr. Zeck from Germany showed a nice data that to use a gadocytic MRI right from the beginning to assess liver metastasis, in fact, cost saving. And this is example of CT. You look at CT here. I know that you guys like CT because it's easy and you use it all the time. It's very difficult to find any metastatic nodule. If I could have the light dimmed, you will see it better. That is what we like dark room. And here, this is the hepatobiliary phase gadocytic MRI. You can see the dot here. That is the metastasis, right there. Like that. Here and here and here. So there are several of them, and if you try to compare on CT, you might be able to pick something right there. Very difficult. Or right there, very difficult. This is just to show you how tools of hepatobiliary phase gadolinitic MRI is superior to CT. What about gadolinitic MRI versus PET CT? Because PET is, you use it all the time in PET CT. This is a study published recently in 2016 to compare PET CT and gadolinitic MRI. And the result shows that gadolinitic MRI detected more metastatic nodules compared with PET CT, particularly small lesions. Because PET, it's good, but it's not so good for very small lesion. And gadolinitic MRIs are able to detect sub-centimeter metastatic nodule. And as you detect more nodule, it changes management in terms of surgical plan in over 40%. And this is the images from that article. This is PET CT. You can see that they detect, this is only one lesion. But on gadolinitic MRI, you have 3 lesions. So based on this study, the authors conclude that gadolinitic MRI should be recommended in advanced colorectal cancer patients, even after performing PET CT, in order to evaluate small nodules that less than 2 centimeters. And this is another article that's confirmed the superiority of gadolinitic MRI. As you can see here, that overall sensitivity is very high. But if you look at small lesions, less than 1 millimeter, gadolinitic MRI is far better than PET CT or CT. So that is just like the concept of the contrast media and imaging. Now I'd like to bring you into some cases, to see how how we interpret and how we use these imaging modalities. I call it the imaging pearls. Let's start with some case. This is a 56-year-old man, primarily colon cancer, post-surgery. Ultrasound shows liver lesions. The patients did not have prior ultrasound. So surgeons worry that it could be metastasis. So gadolinitic MRI, which the trade name is Primawis, was performed. And this is plain, T1 plane. You give contrast, arterial and venous phase. There is no enhancement that you could see. On T2, it is very, very bright like a CSF. The surgeons see this, they said, this is simple cyst, right? You all think that way. So the question is that, is it a simple cyst or is it cystic metastasis? And if you look at, this is 20-minute hepatobiliary phase, you can see that there are different shades of gray. You see that? You know that movie? Different shades of gray. So there are 2 shades of gray. It's not as sexy as a movie. One is very, very clear black hole, look like cyst. But then you see this gray, this shade here. For me, this is different tissue from this look like cyst. This look like some solid component. So I told surgeon that I think I'm worried about cystic metastasis. Surgeon, you all know that you don't like to biopsy because biopsy change everything, seeding, blah, 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 blah. But in this case, surgeon said, I don't believe you, it looked like cyst to me. So when we don't agree, we go for biopsy. So this is the case of surgeon go for biopsy. So we biopsy it using ultrasound, guiding biopsy. And it turned out to be mucin-producing adenocarcinoma metastasis to the liver. So you guys perform segmentectomy and again confirm mucinous adenocarcinoma. The imaging pearl of this case is that cystic metastasis from mucin-producing adenocarcinoma may mimic simple cyst. Keep in mind that. So when you look at different shade of hyposignal intensity in 20-minute hepatobiliary phase, gadolinitic MRI could be a clue. So this is some useful of example case. Look at case number 2. 57-year-old man, primarily colon cancer, post-surgery, presenting with rising CEA, concern for metastases. MRI from outside study using conventional gadolinium read out as negative sent to our institution. So we used gadolinium MRI, and we always relied on 20 minutes hepatobiliary phase and DWI. DWI is called diffusion weighted imaging. So on gadolinium MRI on hepatobiliary phase, what you will see is you will see some dots like this, black dot. But DWI, diffusion weighted imaging, means that if there is fluid restriction, you will see it's a blind spot. And fluid restriction means that that little dot here has a lot of cells, dense cell. So that's why it restricts the fluid and it turns bright. If this is just simple fluid, it will turn dark. So this is simple ways for you to look at. So if you see something right there, and then on DWI, it shows fluid restriction, that is a sign of metastasis. So you can see here, tiny dots here, and show fluid restriction. Even a tiny one here shows fluid restriction. So these are all small metastases, very, very small, sub-centimeters. So that is the value of gadolinium MRI plus DWI. So imaging pearl of this case is that combination of hepatobiliary phase, gadolinium MRI, and diffusion-weighted imaging pulse sequences is very useful tool for accurate detection of small lesions. And there are papers to support this. This is 2014 in radiology, just again confirmed that gadolinium MR with or without DWI is more accurate than CT, and you should perform routinely in potentially curable hepatic metastases. Look at case number 3. This is a female sigmoid cancer here. MRI is requested to evaluate liver metastases. So, like I show you, you should go for 20 minutes hepatobiliary phase and look for black hole, right? That is the fast way for you to look at. And you see multiple black hole here. So, the question is that, are these lesions or metastatic nodules? I want you to be aware of all these pitfalls. So we go for DWI, like I said. You can see that only the big one here that show fluid restriction, just this big one. And on contrast, this big one show rim enhancement. So this one, problem metastasis. If you look at T2, this large lesion shows kind of dull gray signal intensity. It's not as bright as cyst. So this is metastasis. But then these tiny other little dots here, if you look at T2, see that? It is bright as a fluid. So these are cysts. Cyst does not show fluid restriction. Cyst will show very bright signal on T2, but the true lesion like DWI would not show on bright at T2, will be dark gray like that. So with these kind of different tools on MRI that we perform, it becomes a very useful tool to detect and to distinguish several lesions. So in this case, only single metastasis, others are cysts, so your management will change. In this particular case, surgeons go on for resection and confirm these lesions by intra-op ultrasound, can confirm that those are cysts. So this is a companion case. You can see here that similar lesions here, the big one and small one. Again, the same question, are these nodule metastases? Again, we go for DWI. The big lesion is quite clear, but you can see now that all these little tiny dots, they all show fluid restriction. Means that even though it's small, it's packed with cells. It usually tells you that there are some dense cells which imply that they are metastases. So imaging pearl in this particular scenario is that 20-minute hepatobiliary phase MRI is sensitive for liver metastasis, but not specific. Cysts and metastasis may look the same. So interpretation, it needs to do in conjunction with other pulse sequences, particularly with DWI. It's a very good tool. And then you might use contrast, dynamic contrast study, and sometimes T2. This is my last case, young female, underlying FAP, familial adenomatous polyposis syndrome, and CA colon, status post total colectomy and chemotherapy. She received chemotherapy. MRI was performed for some reasons, and then you see multiple enhancing nodule here. Your first gut reaction is, if you see nodule, it got to be metastasis, right? So the question is that, are these hypovascular nodules liver metastases? Again, we use hepatocyte-specific contrast agent, and as you can see here, these show strong uptake of the contrast. You see that before it's black hole is a metastasis, but this is the white dots. That mean that these nodules, they uptake the contrast. That means this nodule contain functioning hepatocytes. It's actually good part of the liver that proliferates and become the condition called nodular regenerating hyperplasia. These are not metastases. So this condition is associated with immunosuppressive or anti-neoplastic medicine that will cause sinusoidal obstruction and then cause heterogeneous portal blood flow, and then the liver have the respond to it to become regenerative hyperplasia, which is the attempt to help the liver to work. So do not think that this is metastases. So per in this case is that nodules in the liver with primary CRC are not always metastases. Hypovascular liver metastasis from primary colorectal cancer is very unusual. It's usually hypovascular. So you should think about nodular regenerating hyperplasia, and 20 minutes gastroscopic MRI will be helpful. So in conclusions, liver is the most common metastatic site for primary CRC, and surgical resection for cure is possible for isolated liver metastasis. So you need to have tools to accurately diagnose and assess liver metastasis, and imaging plays a role. CT and MRI are good. MRI is better than CT, particularly if you use combination of hepatocyte, hepatobiliary phase, and diffusion weighted imaging. PET reserved for selected case. So to question the answer of what is the best tool to detect colorectal liver metastasis, for me right now is gastroscopic MRI using the combination of 20-minute hepatobiliary phase and diffusion weighted imaging. With that, I thank you all for your attention.